Skateboarding is hazardous. Hall of Meat fails. What happened? How did it happen? And what happens next? Stay tuned to find out. Hey everybody, Dr. Chris, orthopedic surgeon and sports medicine physician. Welcome to my channel, your #1 stop for information on broken bones and other things.
That's a little doctor joke we like to make around here.
So today we're talking about fails from Hall of Meat. For those of you who don't know, the Hall of Meat is an Instagram channel which is hosted by the magazine Thrasher. Thrasher is a skateboarding magazine. So while I was looking around on Instagram and on YouTube for videos on skateboarding, I came across this channel, the Hall of Meat. And oh boy, it's a doozy. So basically the Coles Notes version is this. If you're a skateboarder and you want to have your fail or your bail hosted or highlighted on this Instagram channel, then you basically will send it into Thrasher magazine. They pick the ones that they like and then they put them up on the Hall of Meat. So as I've said with some of my other videos, I am not an avid skateboarder, so I don't really know what any of these moves are called. So if you know what these moves are called, be sure to let me know in the comment section down below. So for the first one, we have this young man who's going to basically jump down the stairs on his skateboard. Like, how hard could that be? Couldn't be that hard. So in this clip, we can see that the skateboarder successfully clears the set of stairs. And I think that's about 5 or 6 stairs that he jumps down. Immediately as he lands on the ground, he starts to lose his balance and he falls backwards. When he falls backwards, his right foot slips off the skateboard and falls onto the ground. Unfortunately, his left foot is still on the skateboard and his body continues forward with momentum while his right foot is planted. And we can see that as his body continues forward with the momentum of the skateboard, his lower leg starts to internally rotate on the planted foot. That's kind of the same thing as your foot externally rotated on your fixed body. But either way, it causes the same thing to happen. And that's an external rotation force at the level of the ankle. The skateboarder falls to the ground after he attempts to stand up, only then realizing that his foot is on at a 90-degree angle, externally rotated to what it should be. And that just basically means that it's turned 90 degrees to the outside from where it should be normally aligned. The injury that would typically be caused by this type of mechanism is a fracture dislocation of the ankle. Usually this is a problem that's going to require an open reduction and internal fixation, which just basically means that we are going to cut the ankle open, usually on both sides, and we're going to put a plate and screws on the outside or the lateral part of the ankle where the fibula is located, and then we're going to put screw fixation plus or minus plate fixation as well on the medial side of the ankle or the inside part of the ankle where the bump is located at the end of your leg bone or tibia. So not to be outdone, we have another young man who's going to jump a set of stairs. In this clip, we basically have the same setup as with the first skateboarder, except this time we're looking from the opposite direction. And again, after he clears the landing, we can see that he starts to fall backwards with his momentum bringing him off the back of the board. His foot is in a plantar flexed position, and this just means that the toes are pointed downwards. As a result of all this force being placed on the foot in this position, we can see that the foot is externally rotated approximately 120 degrees. Yes, that's right, you heard me correctly, 120 degrees. Not 90 degrees, but 120 degrees. Not all the way backwards, but like almost all the way backwards. And normally your foot and ankle don't do that. So 120 degrees definitely falls outside of the range of what is acceptable at a hinge joint. And anytime you take a joint outside of its range of acceptable motion, bad things are going to happen. As with the first skater, this young man suffers a gross external rotation deformity of his ankle. That is until an orthopedic surgeon or some other medical professional reduces it back to its anatomic location. And as with the first skateboarder, this is something that will require open reduction and internal fixation in an operative setting to restore his normal alignment of the ankle joint. And I showed these two videos back to back because they shared a similar mechanism of injury. And if you've watched my channel in the past, you know that I say this frequently, and that is that bones are really good in compression, but they absolutely suck in rotation. And these two Hall of Meat bales show exactly why that is. Not only do skateboarders like to jump down from things, but oftentimes they like to jump over things as well. So in this clip, we have a young skateboarder who is going to jump over a low wall onto the sidewalk down below. So unfortunately for this young man, as he attempts to jump over the low wall, we can see that while the front of his board clears the wall, the back of the board clips the wall as he is going over. This causes him to lose balance and he falls backwards to the back part of the board as he lands onto the sidewalk down below. The board shoots out from underneath him and he falls backwards onto his outstretched hand. This is what is known as a foosh mechanism. Fall on outstretched hand. Foosh. And a foosh mechanism is typically associated with fractures or injuries of the upper extremity, or in other words, your arm. One of the most common types of foosh injuries is a fracture of the wrist or of the forearm. And we can see that immediately as this skater turns towards the camera, because we notice that he has suddenly developed a second elbow in the middle of his forearm. This is what is known as a both bones forearm fracture. Fortunately for this young man, it is a closed fracture, meaning that the bones have stayed inside the skin rather than poking out through the skin. So that's a good thing. But if we watch this video further, we see that this is nothing new to this young man. Because when we see his x-rays, we see that this new fracture has occurred directly at the end of the plates, which were used to fix his previous forearm fracture. Yeah, that's right. He previously had suffered a both bones forearm fracture, for which he had undergone an open reduction and internal fixation with plates. And then he subsequently refractured his forearm at the end of the plates. Well, I guess the good thing is that those plates did their job. We can see here from the x-rays that the fractures that he has suffered are transverse fractures. And that just means that the fracture plane travels perpendicular to the long axis of the bone. And that just means that it goes straight across the bone. Not on an angle, which would be an oblique fracture, not on a spiral, which would be a spiral oblique, but straight across, transverse fracture. So now that he's suffered these fractures at the end of the plates, which he had previously had put in place, how are we going to treat these fractures moving forward? Well, if we look at the x-rays, we can see that his previous injury had completely healed prior to this most recent injury. Therefore, we know that the current plates are not really serving any purpose. So when planning to operate on this current injury, part of the procedure would include removal of his previous internal fixation, meaning we're just going to take the old plates off. However, at each of the locations where there had been a screw previously, obviously there would be some holes in the bone. And these holes would serve as potential sites where the bone could break again in the future if we didn't do something to protect against that. So while in the previous circumstance, they had used short plates for the fixation of his fractures, 5 and 6 hole plates, in this current situation, we would use long plates to fix each of these individual fractures. And the reason here is because we want to make sure that we would bypass those potential areas of weakness where the previous plate have been screwed onto the bone. With long enough plates and an adequate time for healing, we would expect that these fractures would heal normally and that this young man would go on to do all of the things that he likes to do in the future without any difficulty. So in this next clip, we have another young man who's attempting to clear the stairs. And unfortunately for this young man, his board doesn't even touch the ground wheels first. At some point while he is in the air, the board starts to rotate, and so that when it actually lands on the ground, the board lands on its side. And that's generally not a good thing if you're trying to land on the board. So unfortunately, he is unable to stick the landing, and obviously he falls forward off of the board, which has now stopped moving on the pavement. This young man also falls forward onto his left-hand side with a foosh, fall on outstretched hand mechanism. And just as with the previous skater, he suffers a both bones forearm fracture. Once again, he is fortunate because this is a closed injury, so he doesn't have to deal with the additional complications that are associated with open fractures. Generally speaking, the two main complications associated with open fractures include infection and prolonged healing times. But this guy doesn't have that, so he's fortunate. As we roll the clip forward, we get to see his x-rays, which show a both bones forearm fracture, which has occurred at the level of the junction between the proximal and the middle thirds of the forearm. And this is just a way for us as orthopedic surgeons or physicians to describe the location of the fracture to one another so that we know where it is. And basically, we like to divide the bone into thirds. And those thirds are the proximal third, or the part that's closest to you, the middle third, and then the distal third, which is the part that is most distal or farthest away from your body. So we can see here that the fracture has occurred closer to the elbow, so we know that it has occurred at the junction between the proximal and the middle thirds. As with the last skater, this is something that will be treated operatively, open reduction, internal fixation, putting a plate on each of the bones of the forearm. And typically, for both bones forearm fracture, this is something that will require two incisions. For some of the fractures that we can treat these through a single incision. However, because we like to use what are called internervous planes when we operate, we need 2 incisions for this fracture. Each of the groups of muscles in your body are innervated by particular nerves, and each of those nerves travels down a particular path. When we operate, we want to make sure that we do not damage any of these nerves to these muscle groups. To fix this fracture, you would require 1 incision to fix the ulna, which is typically right along the ulnar border on the pinky side of your forearm. And then you would require a 2nd incision to approach the radius, which could be done through a dorsal incision, or could be done through what is called a volar incision on the inside aspect of the forearm. Whether to use a volar or a dorsal incision to approach the radius is a decision that is based on the location of the fracture and surgeon preference. In this case, if I were operating on this fracture, I would use the ulnar-based incision to fix the ulna, and I would use a volar incision on the inside aspect of the forearm to fix the radius. And basically, I would use plate and screw fixation for both. Bob's your uncle, you're done. Sometimes skateboarders want to jump from down on the ground up onto higher things, such as walls, railings, or platforms. In this case, we have a young man who's attempting to jump up onto a concrete berm. And unfortunately, as he jumps up onto the top of the berm, the skateboard slips out from underneath him and he falls directly onto the berm. Now obviously, anytime you're falling to the ground, one of your first reactions is to reach out to the ground to try and slow your fall, to protect your head, because everybody wants to protect the computer. That's what matters, protecting the computer. So it's a natural reaction for you to put your hands out to try to stop yourself. And in this case, this young man does so as his body is still moving forward and rotating through the air as a result of falling off the skateboard. And we can see that immediately as his left hand hits the ground, that something is just not quite right. And it doesn't take very long for me to see what's wrong. Can you see it? As we look at the slow-mo replay, we can see that 2 or 3 of his fingers are now pointing at an awkward angle, other than where they should be. And when we look more closely, we can see that both the 3rd and the 4th finger are now pointing at a 45-degree angle away from the body at the location of the 1st interphalangeal joint. And that just basically means your first knuckle on each hand. The interphalangeal joints are the joints between each of the 3 bones of your fingers. And we have a proximal interphalangeal joint, which is the knuckle which is closest to your body. And then we also have a distal interphalangeal joint, which is the knuckle which is farthest away from your body. Now, your thumb, which only has 2 bones, only has an interphalangeal joint. It's not proximal or distal because there's only 1. So it has 1. But the rest of your fingers have 2. Both a proximal and a distal. And we can see here that the 3rd and the 4th fingers on his left hand have been dislocated at the proximal interphalangeal joint. How do I know it's dislocated? Well, the interphalangeal joints are basically hinge joints, which means they only do this, bend. They don't go sideways. And we can see here that his fingers are on sideways. So this tells us that at the very least, he has suffered dislocation. He may have also suffered fracture dislocations of those joints, but more than likely this is just a dislocation. So once this young man receives medical attention, he will have to undergo a closed reduction. And if he is fortunate, and this is only dislocations, then he will require cast or splint mobilization for a period of approximately 6 weeks. And this will be followed by a course of physical therapy to restore the mobility to his hands. So here we have a young man who is attempting to do a trick on a half pipe in a house, because that's a good spot for a half pipe. So basically, this young man attempts to do a small trick to enter into the half pipe. Unfortunately, he doesn't land it successfully, and he falls off of his board as he tries to stick the landing. As the board has wheels, it continues to move forward. As his feet are on the board, his feet also continue to move forward while he falls backwards. And he falls with a whoosh mechanism with his arm behind him. As a result of the forward momentum, his body travels away from his planted hand while he falls to the ground. This causes an element of rotation to be introduced at the elbow, which is typically a hinge joint. And I told you before that a hinge joint generally does not accept any significant amount of rotation at that joint before bad things occur. And we can see that as soon as he stands up that there is a gross deformity, meaning it is visually obvious, a gross deformity of his right elbow. When they show a picture of him holding his elbow afterwards, we can see a dimple on the outside aspect of his elbow, and this leads me to believe that he has suffered a lateral dislocation of his elbow as a result of the rotation mechanism of injury. This is an injury that will require a closed reduction of the elbow under sedation. So this just means that they're going to give him something for pain and something to help him relax. And then a physician is going to pull on the arm and try to restore its normal alignment. If they are unable to do so in a closed manner, meaning without opening the skin, then this problem may require an open reduction in order to restore it to an anatomic position. After the elbow has been successfully reduced, the physician will assess it for stability. If it remains stable after reduction, they can treat this with cast immobilization for a 4 to 6 week period of time, which will then be followed by a period of physical rehabilitation. If the elbow was unstable after it had been reduced, then this will also require surgical repair of the stabilizing ligaments on either side of the elbow. In rare cases where the elbow is extremely unstable after reduction, then this may also require additional stabilization with an external fixation frame after it has been reduced. So here we have a video of a young man who is attempting to jump onto a railing. Unfortunately, he misjudges the landing on the railing and he comes up short with the board. The board falls to the ground, but his feet hit the railing and he starts to tumble in the air as a result. And he bangs into the railing with first his chest and then with his right arm as he rotates through the air. And before he even comes to a stop on the ground, he knows that there's something wrong with his right shoulder. And we can hear him say that I think my shoulder is out again. And he tries several times to reduce it himself, but he is unsuccessful. Fortunately, there is another skateboarder there who is able to help him to reduce the shoulder to get it back into normal position. Now, usually, this is something that will be done in a controlled setting, in a hospital, and under the influence of some sedation and some pain medication. And although I don't quite agree with the mechanism that the skateboarder used to reduce his shoulder, they were successful in the end, and they were able to get it back into position. So from the sounds of it, this is a young man who has had a history of dislocation of his shoulder. Studies tell us that if he is a young active man and he has had even one dislocation of his shoulder, that he is more than likely to go on to have additional dislocation events until his shoulder is stabilized with a surgical procedure. These days, a shoulder stabilization is a procedure that can typically be performed through arthroscopic means, meaning that the whole operation can be performed using 1 centimeter incisions around the shoulder through which we put a camera and working instruments. Usually after a dislocation event or after a shoulder stabilization surgery, the patient would be immobilized in a sling for a period of time, after which they would engage in a course of physical therapy to restore range of motion and strength to their shoulder. So there you have it. Today I've been looking at Hall of Meat fails. Be sure to like, share, and subscribe. And as always, that's been a word from Dr. Chris, not your everyday ortho.
Just a flesh wound.